My name's Joe Murray. So I'm in the Department of Psychiatry, but I'm not a psychiatrist. I come from a criminology background. I did my PhD in the Institute of Criminology here, and I've always worked on longitudinal studies of crime and violence, and the work I'd been doing when I was living in Cambridge was based on a UK longitudinal study, a bit with Manuel on his Swiss one, on others around Europe and the US. And in recent years I've been living in Brazil and working in Brazil on a longitudinal study there. And I want to talk today about that work and about the issue to what extent risk factors are similar in different parts of the world. So it's really nice being at this conference where there's a lot of recognition of the importance of trying to understand these issues in low and middle income countries, because quite frankly at the criminology conferences I'm used to going to, that's the importance of the levels of violence in many low and middle income countries is pretty much off the agenda. So I like to start with these maps, and there's a nice website where you kind of start with the world land area. Okay, that's the size of the countries by land, and then the countries get distorted in size according to a characteristic of the country. So this is where most of the world's population lives, of course. A large number in China and India, and then it's slightly old data, but the picture hasn't changed much when you look at where most of the world's homicides take place in Latin America and Sub-Saharan Africa. And then they've also got a data set behind this website looking at where most publications in scientific journals come from. And there's a big mismatch. So this is, what I think is really concerning. And but I mean, we've got to bear in mind that this is scientific research that could be on anything, and it could even be about what's going on in low and middle income countries. So if we turn now to where the kind of longitudinal studies come from that have really informed a lot of the thinking behind which mechanisms should be targeted when we develop intervention programs. These have been reviewed, the major studies, and there are a number of reviews that have brought them together and meta-analysed the findings and shown quite consistent results. But this is where they've been done. So, North America, Europe, Australasia, and just one in a country classified as low and middle income, Mauritius, very small island with quite a low rate of violence. So this is what I want to talk about today, is the issue of to what extent we can expect the same risk factors that have been identified in those studies to apply elsewhere. And and those studies have informed major reports. So if you look at, I'm today specifically talking about youth violence and what risk factors predict youth violence. And if you look through the World Health Organization report on youth violence and this kind of model that gets used a lot, then it's mainly those studies that have informed which risk factors are important at different levels, mainly on the individual relationship level, a bit on the community. Obviously, you need different types of cross-national studies looking at macro-level factors. One key question, you could put the question like this, that when we look at that kind of ecological model, do the risk factors measured at an individual relationship level, do they have different effects depending on that broader social context? And just to kind of motivate this further, I think you can think of three kind of conceptual ways in which there might be differences if we look in other countries to those that have been studied in longitudinal research to date. So first of all, there may be, because of the different contexts, there may be, and different prevalence rates of different problems, there may be risk factors that just haven't been studied at all. So, I mean, the kind of poverty levels in terms of living in shanty towns, you can't find in the UK that kind of environment of a shanty town with this level of poverty, and many of the kind of associated factors with that, to do with severe malnutrition, for example, may just not have been explored to date. So that's one reason why we can't simply assume that just everything that's been found in the studies in the high-income countries replicate. Secondly is what I've referred to already, that you may get an interaction between the risk factors. It may have different effects because of the social context. So that if there's very strong social adversity in the context, that may swamp out individual level differences in the effects on future violent behaviour, for example. And then thirdly, I think you can think about the effect of cumulative risk factors, where the common model is kind of linear increase in risk according to the number of risk factors that youth are exposed to. And so this is real data coming from the Pittsburgh Youth Study in the United States, showing that. But it may be that the level of exposure stops at that point, and there are higher levels of exposure where we don't know what happens. So this is just hypothetical, but it's possible that in contexts where cumulative exposure is even greater, that there may be a kind of levelling off effect, such that each additional risk factor imposed may not have the same cumulative effect on risk for violence. So those are just some sort of conceptual ways of thinking about how risk factor effects might differ. What we thought was that, okay, so if you go to the major reviews, then they don't show many. They show the list of studies that I had on a map earlier, but it's possible that those reviews have been done by people in English-speaking countries, and they just haven't picked up studies that are going on elsewhere because of language issues or for whatever reason. So we've been doing systematic review just to try and map out what evidence exists in low and middle income countries. So searching in 6 different languages with over 60,000 possible studies that have been screened. And it's a very broad systematic review just for any studies that have looked at correlates in cross-sectional studies or risk factors in longitudinal studies, either for children's conduct problems or for youth crime and violence. So there are just over 500 studies that had at least 100 participants in a general community sample with some relevant results. So that's pretty interesting. But 35 of those had a longitudinal design, and of those 7 had a measure of violence as an outcome in these 6 countries. So to have 7 studies in all those countries with that major issue of violence across them is clearly, it would be desirable to have more. It's not to say there aren't many interesting and very valuable other types of studies going on across the world, but this is just focusing on longitudinal studies with looking at the developmental issues in relation to violence. So what I want to present now is I've been working on the study in Brazil, and just to show you some what the study is and some first results from it.
Joe, were the ones that the remainder after you've taken the 7 youth violence ones, what outcomes did they have?
It would be mainly childhood conduct problems.
Okay.
Yeah.
And you weren't requiring to be representative samples or anything, but not. Was it excluding the clinic-based samples?
Yes, it was. So the eligibility requirements are at least 100 participants in. It was quite hard to sort of operationally define, but in a general community sample, and with relevant measures and a report of associations. Okay, so the context in Brazil, it's got a high homicide rate of 1,000 homicides per week. So in fact, Brazil is the country with the most homicides occurring anywhere in the world, partly because it's got a big population, but also the rate is high. And these studies I'm working on take place in a town called Pelotas, which is right in the southern area of Brazil next to Uruguay. And Pelotas is a town in a relatively rich state for Brazil, but the town is relatively poor for that state. So it's a sort of small to medium-sized town, and as you can see, it's got a lower homicide rate than the rest of Brazil, but considerably higher than somewhere like the UK, which has a rate of about 1 per 100,000. That's a few photos, show you what Pelotas looks like. It's really incredible what's been set up in this town. In 1982, Cesar Victoria and Fernando Barros were doing their PhDs at the London School of Hygiene, and they monitored all hospitals in the city of Pelotas in that year, throughout the whole year, but they were very concerned about infant mortality, child nutrition and so on, and did a cross-sectional survey of all live newborns in the city of nearly 6,000 children. And they were interviewing the mothers and collecting medical information, and there was a 99% response rate. So this is the total population of the city born in that year that was included. They got money to follow those children up the following year, a subsample of them, and it became more and more interesting, and they've succeeded in continuing to follow them up to this day. So, and they've done very well in terms of the proportion who have been retained in the study, 75% in 2005. So this is, I think, it's the longest running birth cohort study in a low or middle income country. And it was so successful and has had a great impact on many areas of child health, about breastfeeding, growth curves and other things, that they set up another one with kind of almost identical methods in 1993. There were fewer children born that year. The population has been going down. And again, they have been following this younger cohort up ever since then. And each follow-up is kind of mapped on to try and to allow comparisons across time as well. So they're epidemiologists with focus on health, and I came to work with them to look at violence in these cohorts when this cohort was about to turn age 18 and a follow-up was being planned. And so we've been collecting self-report data and official records on crime and violence. And the official records have been fascinating to collect, a lot of work.
requiring going to all sorts of different institutions. And so we've managed to do that for both cohorts to see who has an official record by age 30 in the 82 cohort, and age 18 in the 93 cohort. One thing that I found really interesting is that the police records in the state of Rio Grande do Sul include data on victims and witnesses as well. So I'm used to, in the UK, if official records are searched, then for an individual study participant, you'll know their history of offending. But this has also given us their history of victimisation and witnessing of crime, with all the caveats of official records. But that's something I hadn't anticipated and will be interesting to look at. So just look on the right to begin with. So any criminologists are very familiar with the classic age crime curve, which shows in numerous studies the increase in recorded and self-reported crime during adolescence, with higher rates of non-violent than violent crime, peaking in late adolescence, and then slowing down after that with a later peak for violent crime. So on the left is what we've been finding in the 1982 cohort in Brazil, and it's obviously very different. So both that the level of there's difficulties in comparison, obviously, of official data, but the levels of violent crime recorded in Pelotas become higher than the non-violent crime. The peak, we don't know what the peak is because it's flattened out and hasn't, demonstrated that it's going to be going down consistently. So this is very interesting and kind of points towards the possibility of really important processes in the lack of what criminologists call desistance from crime, that drop away from participation, as perhaps being particularly important rather than the factors involved in initiation. It could be, but so there are lots of questions to be considered. And
excuse me, just to say,
yeah.
This is a different scale. So isn't the red? I mean, what is the difference? The most striking is that the blue is down rather than the red.
Yes.
Is it the same? Because it's 106. If you put the left with the same scale of the right.
Yes. So this is the scale is different.
Yeah.
1.2 million here because it's for the whole country. It's the absolute number of crimes in the United States.
Absolute numbers,
yes.
Rates.
No, they're not rates. And it would be helpful, I agree, to compare the rates.
Okay.
Yeah.
Can you
I
remind
agree.
us what the data is in Pelotas? Is it parallel? Does it parallel the US data?
Sorry, what do you mean?
Is it official?
This is officially recorded police data. This is the nearest equivalent, yeah. Okay. What I've been doing as well, there's a very nice coincidence of a study in Britain that's very nicely matched with the study in Pelotas that started in 93, so called ALSPAC, which is a longitudinal study of births around the city of Bristol, which started almost at the same time and has carried on and has quite a few similar measures. They didn't do as well in the UK in terms of follow-up, and that's an issue. So what I've shown you now is comparing the Pelotas 93 cohort and this British one on what's available to compare. So I would love to get into some of the other possible mechanisms and so on, but what's best for comparison in terms of the measures are, first of all, at age 11, just by chance, they use the same measure of children's behaviour with the parents, the Strengths and Difficulties questionnaire for conduct problems, hyperactivity. At age 18, which was when I was kind of coming into work, we decided, okay, well, let's they'd used a self-report crime questionnaire in Bristol already, and so we did a lot of work in adapting that and testing it, and used the same one in the follow-up in Pelotas at age 18. And then there are a number of fairly objective measures of kind of social demographics, and then kind of perinatal health indicators at birth that can be looked at. So these kind of social demographics are ones that are quite consistently shown to be associated with later crime and violence in other studies. The early health ones we heard this morning about the importance of thinking about early child healthy development and possible impacts on the brain and so on. So they're more kind of exploratory, but there are theories about the effects of these. So this is at age 18, the proportion of the youth who have self-reported a violent act in the last year in Pelotas in Brazil and ALSPAC in the UK. So both for boys and for girls, there was a higher self-report prevalence rate in Pelotas and ALSPAC. So that kind of fits with the official records that we know. You may kind of course, question whether there's over-reporting generally in one place or under in the other, or it's about different response rate. What was quite interesting was that when we looked at non-violent crimes, it was the reverse, suggesting that it wasn't just a general over-reporting or anything, because in actual fact, in Britain, there was self-reporting more non-violent crime than in Brazil, both for boys and for girls. So now I'll show first of all, just the exposure at birth. What are children being born into in each of the two places on those factors that I mentioned earlier? And across, so these are the prevalence rates of these different risk factors in the two countries, and the orange bars showing that generally children in Pelotas were exposed to more social demographic adversities and more kind of perinatal health risks than children in Britain. And then we consider, well, what are the associations between these and this self-reported violence at age 18, and are the associations similar in the two places? So this shows the risk ratio for each individual risk factor and the probability of reporting violence. And then, so risk ratio, anything above 1 is showing an increased probability of self-reporting violence. And this is for girls. And as you can see, most of these risk factors are in the direction of predicting increased probability of violence. And you can see a kind of general pattern that the strength of effect is stronger in the British cohort than in the Brazilian cohort. This is the same graph for boys, which is in both studies it looks like smaller effects than for the girls, and particularly for the Brazilian boys, these effect sizes are all but one very close to nothing. This risk ratio of 1 indicates no association. So all these things measured at birth, this is a very restricted set of factors measured, but it's impressive how little they're predicting, particularly in Brazil. So is there any clarification needed on that?
How do you group them? It looks to be they're sort of individualistic risk factors, but the phenomenon is community violence, and so the these factors are not indicative of the conditions in the community.
Yeah, so this would be, the conclusion I've come to with this is that these are not nearly as important as as the rest of what goes on in people's lives after birth, clearly. So at the same time, I mean, these are very small effects, but there's another interesting question you can pose with all of this. So if you think of that initial graph that there was different prevalence rates, there was a higher rate of violence amongst girls in Pelotas than in ALSPAC. So the ratio, there was 2.41 times the number of girls reporting in Pelotas compared to in ALSPAC, okay? And actually this is following from the kind of work Francis has done with some people where compared across time differences in cohorts and looked at how much risk factors might explain that kind of difference across time in rates of conduct problems or violence. And what we did here was to look at to what extent that difference between Brazil and Britain was explained by introducing by adjusting for those risk factors measured at birth. And basically there was a reduction in that ratio estimated of 12% for girls, and for boys that ratio adjusting for the risk factors kind of reduced by 8%. So a kind of small contribution to what this cross-national difference is.
Can you just go?
Okay. Yes.
Can you just go back to the girls? The risk factors.
Yeah.
Advance.
This one or the
Before it. Yeah. Do you know there's some of those things are statistically significant?
Yeah. Yes. It was a bit hard to sort of demonstrate everything on the slide. I think pretty much those that are above about 1.3 are significant.
I mean, no, the difference between...
Oh, the difference between, yeah. So there's only, when you look at them individually, although, as I said, there's that kind of pattern of a greater effect for in ALSPAC, there's only one here that's where you can say this one is significantly bigger than this one in an interaction. But you get a bit more power, I just didn't have time to show it all, if you kind of look at the cumulative number of risk factors. So we did that, just summing the number of socio-demographic risks, the number of the early health risks, and there you see on both counts a stronger effect in Britain than in Brazil.
These don't look like risk factors. I mean, I don't know what the relationship could be between urinary infection, pregnancy, and violence. It doesn't make any sense as a medically qualified person to me. Okay. But maybe.
Well, yeah. I mean, that was certainly the one that you might question. As I say, it's exploratory. I was consulting with people in psychiatry here. Said, well, don't drop it. Because they suggested there could be impacts on brain development via...
Perhaps they're all markers of low socioeconomic...
Absolutely. So what Rachel pointed out earlier, the limitations of just simple epidemiology looking at risk factors. We don't know what the causes are here at all. Okay, these are and so stopping at this point would, you don't gain much. And
I can see that a few more people have their hands up, but I think we should.
I should close.
Sometime, if you want to say some final conclusions,
fine.
and then we can hold the questions for the discussion time.
So there are two main things I want to say here. One is that there are whole areas of early child development influence of parenting and then on into youth adolescence with the gangs to explore, and this is just a very small subset at the beginning. We just started at the beginning, say, well, let's have a look. And second, as Rachel has pointed out, that the key step next is to try to identify causal mechanisms, what's behind the risk factors for which you need to do different types of analyses. So these are first results to kind of share, to show you where we're starting, and then that's a summary of what you've seen, and then so where we'll be going to try to look at how, because we have data through time, how each different developmental period, what is affecting what through time and accumulating over time, and ideally analyses of change through time to try to better unpick actual mechanisms as opposed to just simple associations. And also looking at victimization and what influences that, and also what the consequences are. So that's where we've got to. Thank you for listening.